with you. I think most of you know I'm a melanoma patient, and I've been going through 3 different clinical trials. Although CAR-T has been, there is and there were clinical trials with melanoma, I was not the right candidate when I was dealing with melanoma to a CAR-T, which was a little bit disappointing to me as I was trying as well. So I also look at it as on a personal level, really interested to learn what is going on, what's new, where is the innovation, what comes into play when it comes to CAR-T and cell therapy. So we'll give people a few more minutes, maybe 2 more minutes, and we'll officially kick it off. In the meantime, Dr. Josh or Dr. Mansour, would you like to introduce yourself a little bit?
Yeah, absolutely. So I am a board certified hematologist and oncologist. I'm actually triple board certified in internal medicine and hematology and oncology as well. And then I did additional training and fellowship at Stanford in cell therapy and in bone marrow transplantation. So I have that background and knowledge. I'm very excited to present this information to you all. The way that I'm going to approach this talk today is as if you were a patient of mine coming in to see me. I'll go through the different steps, kind of what cell therapy is, the difference between cell therapy as a broad versus CAR T cell specifically as it's a specific part of cell therapy, walk you through the different steps, why we use it, what can happen, what follow-up looks like, what's FDA approved, and then what clinical trials, not specific clinical trials, but in terms of what cancers and tumors clinical trials are ongoing right now to see if that's something you might explore later on.
That makes a lot of sense. And he didn't say it, but also is one of the nicest people I know I've met.
Thank you. I
So,
appreciate that. It's been a pleasure so far, and I'm very excited about this talk. It'll be fun.
so let's kick it off. So the floor is yours.
All right, I'm going to share my screen now. Let's just make sure we can get everything. All right, can you all see that?
Yes, we can.
Okay, perfect. And let me put it into, there we go.
Perfect.
All right, so I introduced myself. My name's Joshua Mansour, and I'll be talking to you all about cell therapy. So what is cell therapy? So the simple definition is cells transfused or injected into a patient to evoke a particular response. So like I said, this is a broad topic that can include various different treatments. Cell therapy as a whole, when I talk to patients, can include autologous stem cell transplantation, which means your own cells, allogeneic stem cell transplantation, which is someone else's cells and having a donor, or CAR T cell therapy is also a type of cell therapy. So today's focus is going to be on CAR T cell therapy. So why did I put this slide of the history of CAR T cell therapy? Not to go through, I'm not going to go through each milestone from 1986 until 2019 and now the present, but just to give you a broad overview that CAR T cell therapy has been around for over 20 years. What we're trying to find now is how to best use it and what other cancers we can use this CAR T cell therapy and the cell-directed therapy to help us. So CAR T cell therapy, what is it? Well, it's an immunotherapy that helps T cells recognize cancerous cells in the body and attack them. What's the process? I'll go into the process in more detail in a few slides, but overall, T cells are extracted from your body through apheresis, almost like a dialysis machine, if any of you are familiar with that. Then shipped over to a lab. A chimeric antigen receptor is then attached in a lab, and these cells are genetically engineered. After that, they're taken back over to the patient and then re-infused. So they're infused into the body in which that CAR receptor is able to recognize and attack the cancer cells. I'm going to keep describing this and referring to it almost as a lock and key method. And I think that'll help you all understand it a little bit better. So right here, I just briefly show what a normal T cell looks like and how it interacts with a tumor cell, then what a CAR T cell looks like and how it acts with a tumor cell. So in the normal T cell, you have to have the T cell receptor, you have to have a peptide or a protein, and then an MHC or major histocompatibility complex from the tumor cell. So right there, you can see there are several, I don't expect everyone to understand each detail, but what I want you to see is that there are several different pieces and parts that really need to come together. So we were trying to eliminate that with the CAR T cell. We have the T cell that's taken from a patient's body. Then we have the CAR, which is the chimeric antigen receptor, that purple area, that is able to specifically target something that is going to be on the tumor cell. So again, lock and key. So patient eligibility. Not every patient, of course, can have CAR T cell therapy. Later on, I'll talk about some of the FDA approved ones and then some of the clinical trials that are also available. But overall, in general, there are still certain things that we need to look at before saying a patient can go forward with this therapy. So blood counts, your blood counts need to be stable for leukapheresis. What is leukapheresis? Leukapheresis was that process I was talking about with extracting those T cells. So your platelet counts need to be adequate, your white cell count, your red blood cell count, all of that. Next, relative disease stability. Now, why is that? Well, I talked to you all about taking the CAR T cells out, sending them over to a lab, engineering them. All of that takes time. It takes about 2 to 4 week process in between. So sometimes what we'll use is bridging therapy, a different type of regimen in between to hold a patient over from when those are extracted to then when they can be reinfused. Next, the ability to tolerate toxicities. I'll talk about the toxicity profiles later and what can happen as reactions to the CAR T cells. But overall, a patient needs to have adequate organ function. We're talking about lung, heart, GI system, and then neurological status. You can get neurotoxicity as well from CAR T cell therapy and CAR T cell therapy infusion. So that is something to be very careful about. So a review of the process. These are some of the things that I have alluded to previously, but I really wanted to show you a picture to let it all sink in together. So the first step is, again, the removal of blood to get the T cells. And that is right there, an IV. Sometimes a Hickman or a different catheter is also placed in order to connect it to the machine to take those cells out. We then send them over to a lab in which they're genetically engineered, and you get that CAR, again, it stands for chimeric antigen receptor. Those then replicate and grow. We're shooting for about 2 million. So 2 times 10 to the 6th log. That's over a few weeks. And then they're sent back up to where the patient is. The patient, typically before getting CAR T cell therapy, will have a combination of chemotherapy at a very low dose just to subdue some of the other cells. And then the CAR T cells are infused into the patient, and over time will then bind to the cancer cells, release other cytokines to help gather other cells as well to help with the therapy and killing of the cancer cells. So again, this is a living therapy that expands. So I give a little bit of a chart here just to show you. Again, we replicated them before also in the lab. And then once we put them in the body, this is something that expands typically over a week and can last several months. There were studies while I was training as well and some other ongoing studies to determine just exactly how long this therapy and these CAR T cells are actually in the body working and they have been significantly higher than even months to 6 months to a year. So it does continue to work over time. Toxicities. So at this point now, we have infused the CAR T cells into a patient. What happens after? Well, these CAR T cells are working hard to kill the cancer, but some other reactions can also occur. Some of these toxicities, the big one that I tell patients they can almost always expect is some degree of cytokine release syndrome. Now, the degree of that varies depending on the patient, the tumor, and several other factors. But what I tell them is you're going to get very high fevers. You could get some shortness of breath, some fatigue, some headaches, nausea, vomiting, some diarrhea with some GI and upset stomach. Some of the other ones are a little bit less common, but I tell them to always possibly expect the fever, rigors, headache, and fatigue. This typically starts from about day 1 to day 3 and can ongo for several days after. The next big one I talk about is neurotoxicity. So with neurotoxicity, this typically happens, it can start as early as 3 days, typically on average around 5 days, and persist from day about 5 to day 8. When I talk about those day numbers, I mean days after infusion of the CAR T cell therapies. For neurotoxicity, what we typically do with patients is we have them answer the same set of 10 questions twice a day, in the morning and typically mid-afternoon. Some institutions and centers, and also while patients are on clinical trial, will sometimes even do it 3 times a day, so every 8 hours. Why do we do this? Well, we want to make sure that the patient is still thinking clearly, answering questions appropriately. And also one interesting factor of it is we have them write a sentence down. That may seem a little odd. Why are we having patients write a sentence down to determine if they have any neurotoxicity? We have them write the same sentence because fine motor changes in that sentence can actually be an early sign of neurotoxicity occurring. And we want to be able to start therapy and to intervene sooner than later. So the neurotoxicity can be something very mild, or it's something very severe where seizures can occur. Patients have difficulties communicating. At that time, we'll typically add on steroids or other therapy, as well as do EEGs and neurological workup, as well as an infectious workup to make sure that we're not missing anything. Post-CAR T cell management. Now, this slide right here, what I'm talking about is, I'm talking about after a patient leaves the hospital. First thing we worry about is cell aplasia. So again, with the CAR T cells making way also through the blood and the bone marrow, is that your white cell count, your red blood cell count, your platelet count can all be somewhat lower than they typically were or were prior to CAR T cell infusion. Well, with white blood cells, we need to worry about infection. Red blood cells, of course, fatigue, shortness of breath, other issues with that. And then with platelets, risk of bleeding. With all of this, infection is also something to watch out for. So we'll have patients on antiviral therapy, antibacterial therapy. And with the white cell counts and other parts of the immune system being subdued, it's important to watch for infection. The next is hypogammaglobulinemia. It's a fancy term for when the immune system and some of the other fighter cells and antibodies are low. So we need to watch out for that, again, moving back towards infection. So now, for the part that I think you all have been waiting for, is approved therapies, next steps, and all of that. FDA approved CAR T cell therapy now for relapsed refractory ALL, acute lymphoblastic leukemia/lymphoma. This is typically for patients that are younger though. Relapsed and refractory diffuse large B-cell lymphoma. And then now recently, actually over this past summer, relapsed and refractory mantle cell lymphoma. Now, for all of these, typically you have to fail prior traditional therapy in order to get them, but they are FDA approved CAR T cell therapies. So failure of CAR T cell therapy. As much as I would hope that this works in every single patient that we're able to give it to, sadly enough, it's not. So when does it not work? Well, I've described over here, and you have A, B, and C to describe different ways in which these CAR T cells might not be effective. Again, overall, what I want you all to understand is, again, going back to that lock and key method, right? So there has to be an issue with the lock and key method. There can be some form of genetic mutation that can occur. There can be a cell line change. There can also be what's known as epitope masking. So see right there, where it kind of is blocked. This lock and key method is almost blocked. Now, the therapies that I described again that were FDA approved, right? Those are what we traditionally call liquid tumors, meaning blood and lymphatic system. Okay. Solid tumor CAR T cell therapy is now on the rise with clinical trials. Some of you may be asking, well, how come this therapy has been working with those other ones, but we don't see them approved yet for breast cancer or lung cancer or colon cancer? Well, there are a few different reasons why, things that we're working on, but so far, again, there can be a limited array of targetable antigens or proteins that are expressed on the tumor cell that, again, from that lock and key method, we're not able to find to express yet. The other thing is the T cells. Many times, the ones that I've talked to you all about already, we're talking about the blood and lymphatic system. These T cells can kind of flow throughout and kill cancers and tumors throughout that. But having the T cells move into these solid tumors is a lot more difficult. The environment of the solid tumors is more difficult to penetrate, as well as it has some immunosuppressive mechanisms that kind of block and withhold these T cells from going there. Now, CAR T cell therapy clinical trials. I have several of these here listed. Chronic lymphocytic leukemia and small lymphocytic lymphoma, acute myeloid leukemia, myelodysplastic syndromes, relapsed refractory multiple myeloma, sarcomas, hepatocellular carcinoma, prostate cancer, breast cancer, and some brain tumors. These are all ones that are ongoing. The important thing, again, alluding back to this lock and key method, is finding the appropriate antigen and protein that the CAR T cells can attack. So the future, where is this heading? What are we looking for? Well, previously I described cytokine release syndrome, neurotoxicity, and some of the other adverse effects that can occur. We want to improve these. We want to make this safer for everyone. Increasing targets, again, alluding back to this lock and key method, right? We want to increase the targets and the proteins that we're able to then latch onto to help kill. Expanding to solid tumors, getting past some of those barriers that we talked about just now. And then some other things are, can some of the checkpoint inhibitors, which are medications that we are now using for several other cancers, can the addition of those also help, and can it enhance some of the activity? These are all things that we're working on right now, and hopefully with the continuing of a lot of these clinical trials, we'll be able to get more information to help more patients. Now, I'm happy to answer any questions regarding what I've just presented or any other additional questions.
So first of all, I would like to thank you for this really comprehensive overview. And I like to encourage everybody to ask questions, whether if you want to unmute yourself and ask, or you can do it via the chat and I'll communicate. I want to kick it off by asking you a question with regards to the way the T cell fight the tumor, how is it different from the immunotherapy that we've been, some of us has been getting, and we've been seeing to be very effective both on the solid and the non-solid? How's the immunotherapy, PD-L1 and others, mechanism different than the T cell mechanism to fight the cancer cells?
That's a great question. So that question is one dependent on the type of immunotherapy. But if I'm talking just as a broad generalization, a lot of times what those immunotherapies do is they block inhibitors as number one, or they rev up the immune system and the T cells and other immune responses in order to attack the cancer cells, but they are more non-specific. So what we're trying to do is specifically target the type of cancer, and then with that targeting and an additional cytokine release, bring additional immune response to that particular area and to those cells. So it's a little added booster effect.
I understand. We have a question in the chat. Is this therapy possible for EGFR lung cancer that has transformed from non-small cells to small cell?
I am not aware right now of that, but again, a clinical trial can be underway that I don't know about. I think what's going to be important is, of course, talking to your oncologist, looking on the trial trajectory website, among other things, in order to determine if there are those clinical trials that are available. I hope in the future that'll be something that will be used, but I don't know off the top of my head.
Fair enough. Another question from me, while others might want to ask. You mentioned and you in your graph how it's been growing over time. Is that also helping prevent recurrence? So does it prevent recurrence, or does it really get you to the point that you're completely in remission with no existing cell and not just in a net kind of non-visible cell?
Yeah, that is a very good question. So again, it's an active live cell therapy that occurs over time. So what I like to tell patients is that many times what we'll do is we typically do a PET CT about 30 days, 28 to 30 days after the infusion of the CAR T cell therapy. And that gives us a rough idea of where a patient's at. But many times these cells are continuing to work for many months after that. So depending on the response, I'll do another repeat scan in about 3 to 6 months after that to assess, because those active CAR T cells are still working to help decrease the tumor burden and to continue to fight.
Got you. And do they create some sort of also cell learning that the immune system of the body learns to identify and continue the fight? Or is it something that
that we're still learning more information about in terms of how our immune system is recognizing it. But again, this is why we are taking these cells out from the patient and then with the added receptor infusing them back into the cell patient in order to continue for your immune system to understand that it is still your own cells.
Great. So I see 2 more questions. And by the way, guys, feel free to also unmute yourself and ask. So you can. So I see a question here. Where are we with CAR T for MDS? I know there are several clinical trials going on. Mm-hmm. What do you know about the MDS?
So again, still clinical trials that are ongoing. I urge you to find out if you are a candidate or what clinical sites may be holding CAR T cell therapy for MDS. But in terms of response to that, as of now, I don't have much information to present to you.
And you can find, if you are eligible, and sites and the trajectory platform, of course, for free. But I think, like it's been approved for so many others, non-solid tumors that you mentioned before. Mm-hmm. It's easier response than for the solid. Another question: how long does the cell therapy typically last, it relates to what I was trying to ask, and continue to fight the cancer cell?
It can be for several months to even longer than that.
Are there existing stats for the ones that have been approved about
Yeah,
recurrence?
we're starting to get now 3-year data that's starting to come around from the 2018, 2019 trials. A lot of that information still is still now being in the final stage of being processed and released as well. A lot of times what we do have right now is the information in terms of overall survival, disease-free survival, things such as that. But there are studies that are ongoing in order to do cell tagged studies to determine how long those persist. I do know of some that have lasted for over a year. So I can tell you that these are active cells that are continuing to work.
That's awesome. And overall, the information about from the ones that approve about survivorship
has been positive. And I would not be treating patients with this if that wasn't the case.
No, of course, but sometimes it's always a matter of alternative, but it's good.
Oh, absolutely. No, and I do think it again, especially for the ones that have been approved, it is a great treatment that is available. And I'm hoping with more information and with more clinical trials that we will be able to find other cancers that this therapy can be used for.
No, absolutely. Another question, what is the recovery time after the infusion of the cell, requiring how long not to feel fatigue and the other side effect that you mentioned? And I'll add to that, how long do you stay in the hospital and then what's happened following?
Absolutely. So typically you're in the hospital for about 7 to 14 days on average. Um, that is from the time of infusion. Prior to that, though, you are in the hospital to undergo some low dose chemotherapy, usually flu-cy. But now centers are moving towards seeing if patients are candidates to do that first part as an outpatient, actually, and not having to be in the hospital. So traditionally, what I tell patients to expect overall that you're going to be there for about 14 to 21 days. Again, this can change. It can be sooner that a patient's discharged, or it can be later, depending again on those complications that I talked about, including CRS and neurotoxicity, and how a patient recovers from that. Typically, what I've seen is the fatigue can last weeks to a month or 2 months after, but then the patient regaining strength and energy following that. I do have patients, though, that leave the hospital and they're feeling great. The fatigue then starts to wear off and they're able to work that same month. It does vary. A lot of that depends on the fitness of a person prior to going in there, the disease and tumor burden prior to having the treatment, as well as their response to therapy and how the different adverse effects have occurred.
Is it similar that while you're in the hospital to the bone marrow transplant, you have to stay in a completely isolated environment, clean environment, uh, or is it different?
So, oh yeah, so what we do this in the same on the same floors as our transplant patients in order to have a more isolated, as you say, environment. But not that may vary by institution. And again, some institutions are moving towards doing some of it as an outpatient and then moving inpatient, or some are trying to even move this towards an outpatient type of therapy. I think we're still a little bit of ways away from that, but that's kind of a general idea.
Oh, interesting. Another question, can you get the cell therapy more than once? Very good one.
You can through trials. Typically, I know of some ALL patients that have gotten it more than once. Again, this depends on the patient, depends on the clinical trial if it's available, among several other things. But has it been done before? Yes, it has.
And another question for me while we wait for others. And again, I encourage you to ask any question that you would like, unmute or chat. What we've been seeing on other therapies as one of the trends is a lot of combination, right? immunotherapy instead of mono combo of immunotherapy, combination of immunotherapy with targeted, immunotherapy with chemo, targeted with chemo. So everything seems to be like going forward a mix kind of
Yeah.
mode. Is that also what's going on with CAR T or cell therapy in general, or is it still very standalone? Just at the beginning, some chemo to kick it off, and then this is it.
No, you are absolutely right. So that what I think it was the last line of the future that I had on the presentation was how we can, what we're trying to look at now is how we can get some of those other immunotherapies or checkpoint inhibitors to really bolster up that response of the CAR T cell therapies to allow them to really act and to do their job. So those are ongoing right now with clinical trials. Absolutely.
Interesting. Two more questions. And guys, feel free to mute yourself. Aren't you tired of hearing my own voice? So is this therapy beneficial for glioblastoma brain cancer?
Uh, did I hear for glioblastomas?
Yeah, for
Yeah,
glioblastoma.
there's a clinical trial for that occurs at a couple of different centers, I believe.
Yeah, and you can find those, of course, on the platform, on the trajectory platform. Another one, which low dose chemotherapy is giving, and does it that vary by the tumor?
No, it's Flu-Cy that's given, and it does. That's the standard right now for the approved ones or for the approved therapy. Again, depending on clinical trial, will that change in the future? Possibly, but that low dose chemotherapy that's given in the beginning is really to decrease some of the other cells that are around to give the CAR T cells the best chance of really acting and fighting the cancer cells. So I don't want people to think of it as that is really doing the trick of decreasing the cancer itself. That's really just to suppress the microenvironment to allow those CAR T cells to move in.
And we know, we know that cancerous cells are smart, unfortunately. And you mentioned it briefly in our presentation that they tend to mask themselves.
Mm-hmm.
They identify who the attacker is or who is there to, and then they mask themselves from the immune system. They mask themselves from the drugs, and also you mentioned from the CAR T. Can you tell us a little bit more? How do they mask themselves? How often does that happen? Does the CAR T know how to learn and identify even though they mask themselves?
Yeah, so again, that kind of alludes back to the lock and key, right? Well, we know what we do is we take a piece of the tissue prior to determining if a patient is eligible for CAR T cell therapy and make sure that that tumor, right, and that environment does have the receptor that we're putting onto that it presents that protein that we're putting on into the CAR T cell to then go and attack it, right? But not every single one of those cells that's there some might not have it, right? So again, if there is an issue with that and we cannot then lock onto it, that is where one of the biggest issues are. Can it be that it's blocked? Can it be that it's not there? Can it be that it's masked? All of those are different ways that they can kind of escape the CAR T cells. And that's more with, again, the blood and lymphomas type of cancer. With the solid tumors, again, it's the tumor and the microenvironment. We're talking about these very solid tumors, right? So it's sometimes difficult for them to really penetrate and to be able to do their job.
Interesting. It's gonna make me wonder if you take them into the lab, is it like, can you train them even though something is not working? Can you put them in the lab in your little petri and then, like you train a dog or a pet?
Yeah, I wish it was.
Attacking?
I wish it was that simple. As of now, I don't think anyone has found out how to do that, but who knows? Scientists and doctors, among so many other people that are a part of the teams that go into these clinical trials and that go into this therapy, are working hard to figure out ways to improve this. So I'm hoping that in the future, there are still ways that we can better fight the different cancers.
Fair enough. Another question. You guys are still refusing raise your voice. It's a really interesting. So, do the CAR T cell eventually leave the body, and at that point, do the cancer cell return?
Yeah, really good question. So it again depends on the patient, depends on the tumor burden. So they can die off, right? This is a living active cell that's occurring, so they can die off. That's one part of it. And then it depends on how much activity and response has occurred. So if the CAR T cell was able to then attack them and to eliminate the cancer, well, I'm hoping that there's not going to be any recurrence. But if it was not able to fully attack all of the cells and there were still some lingering around, unfortunately, the cancer will either recur or grow.
Another question for you while we wait for additional question from others. So I'm taking advantage. Do they attack also healthy cell? Can it damage the body in any way by infusing those the CAR T into the body? It's changing the biological order of the organism and create some we know that the chemotherapy is really creating damage to also healthy cells, etc. This CAR T as that can create that kind of risk.
Yeah, not as much as some of the higher dose chemotherapies that are non-specific, but can you have organ toxicity and other adverse effects? Absolutely. And that's one of the reasons that in the beginning I discussed patient eligibility, that when we see patients, we want to make sure that they are fit enough to even undergo this. We do lung testing, heart testing, we do any further imaging that we need to do before in order to determine, are they at a higher risk of having some of those organ damages or organ toxicities that occur, especially when that cytokine release occurs and you have multitude of cells and an inflammatory response that occurs a few days after the infusion of the CAR T cell therapy. That can be damaging. In general, though, the toxicity profile is less than other therapies.
That's good to know. Additional question for you, relevant for to the days, this basically the era we live in. Is CAR T making you more vulnerable for COVID? When you're in CAR T therapy, is there a risk of can you still take the vaccination? What's the relationship? Are you more vulnerable? Are you at higher risk? If you can share some lights there, what you've been experiencing also.
Yeah, so because of how our immune system reacts if a patient's going to go into CAR T cell therapy, typically within a few weeks, we tell them that the vaccine may not be as beneficial to them. Right now, what we're recommending is at about 100 days post CAR T cell infusion that we'll have our patients get the vaccine. Are patients more vulnerable to COVID? Well, like I said, they're more vulnerable to infections as a whole. So COVID is included in that. And cancer patients that are on therapies and that they're therapies that lower their immune system, in general, they're more susceptible to infections and to other illnesses such as COVID.
And if someone is taking the vaccine, does that prevent them from participating, from receiving CAR T therapy?
Oh, if they've had it prior, you're
Yeah.
saying?
Let's
Uh,
say I got it today, and then does that prevent me from getting into
yeah,
CAR T?
not that I've heard of, not now. No, that wasn't an exclusion criteria.
Okay, interesting. Guys, any additional question? Even not about CAR T, we have the opportunity to speak to Dr. Mansour. If there is additional question you would like to ask at this point, before I release him to go back to his clinic and his patient. I think while I leave it open and then before we say goodbye, from your, I mean, this is, you've been experiencing it, you've been practicing it, and as a clinician, focusing on that. What is your overall view? Are you optimistic that this is one of, we look at different things now and it's even though some of it is approved, a lot of it is in clinical trials, but you believe that CAR T will become part of standard of care and like offer new relief hope for cancer patients?
Yeah, it's already become a standard of care. The FDA ones that the FDA approved ones that I've discussed already are um, implemented part of the NCCN guidelines and a standard of care moving forward. So these clinical trials hopefully will be implemented in some way. But again, we need the information to determine when it's safest also, and after what therapies will it best be used for the patient. So still a lot of questions to answer, but overall, yes, I'm very optimistic about it and do think that it will be here to stay.
Yeah, it's very exciting days with the cells and CAR T advantage in innovation and the immunotherapy and the targeted therapy. It feels like there is much more hope for us as patients than ever before, I believe. So anybody else, last chance, any question? Not really last chance. You can always shoot us an email and we'll make sure to reply to you with any additional information. So if not, I really, really am thankful for you to joining us today.
Absolutely. No, my pleasure. It was great. Let me know if you all need me to talk to you about it some more later on. I'm
Yes.
happy to.
So reach out to Trajectory. If you haven't done so far, go ahead, build your profile and see what eligible and relevant clinical trials are out there for you. And if you have an additional question to Dr. Mansour, just reach out and let us know. And thank you again for the really great information and for dumbing it up for me and simplifying it and making it less mystified. Very, very useful. Thank you again.
My pleasure.
Thank you, everyone.